And we'll talk more about what that treatment looks like and how you would connect to those places. Excuse me. So this is another kind of representation of the same idea, that we're really wanting to intervene early. So that top line is suggesting that the earlier that we are intervening at those early warning signs or right at that onset of an episode of psychosis, the better that long-term trajectory will look, right? I always complain about this slide. The red line is suggesting, that if we are not intervening early, then the trajectory looks a lot different. I complain and then never change it, but I complain because it suggests that if someone, is getting to an emergency room and that's the way that they're getting into treatment, that's a bad thing. And, this scary red line suggests like, everything is going to be bad. That's not the case, right? This is an oversimplification of what we're talking about. People come to treatment through the emergency room, and that happens, and that's how people get connected, and then they are connected to care longer term. But emergency rooms can also be scary places, right? Can be a traumatic experience for folks. And so the more that we can catch these signs even earlier, the better it is, for us to then connect folks to treatment to perhaps avoid or, reduce the likelihood of needing to go to some of these more, higher levels of care, as much as it might be the case otherwise. This website at the bottom is a really helpful resource. It's psychosisscreening.org. It was developed by colleagues of ours at Beth Israel. And it was developed originally for a primary care audience, but it has a lot of really great resources for folks in any sort of area. It has some suggestions for like screening questionnaires. There's some flow charts to make decisions on, where to go next when you might be working with someone having these experiences. Some of this we'll cover today, but I encourage folks to take a look at that because it's a great resource to have on hand. So this is just another way, in case you didn't get the point already, that early intervention is really what we're going for, right? In terms of that duration of untreated psychosis, or the DUP, the World Health Organization is, really recommends that period be no longer than 90 days in order to have kind of more optimal long-term outcomes. However, on average, folks might be experiencing psychosis for like a year and a half before people are receiving treatment. And so that's a big difference. And so the more that we can be identifying these signs earlier, the better. And as we said, a lot of this ends up happening in crisis settings like inpatient units or emergency departments. That doesn't mean that, now we're on a bad road, of course, but those are scary experiences. And so the more that we can, again, be catching this early, the better. And some of those long-term outcomes, as I was saying, they can be things like difficulty with functioning in the community, difficulty with sometimes some cognitive impairment, sometimes an increased risk of suicide, difficulty with social relationships. And again, when you're working with folks in this age range, you might be one of the first people to be noticing some of these warning signs. So coming back to the case example, I wonder if there are pieces of this case that stick out to folks, things that you would want to ask more questions about, learn more about. And then also, I'm wondering if it brings up any folks that you have worked with yourself, and whether it's reminds you of anyone that you'd want to share a little bit about. So yeah, any thoughts that folks have? Some things that often stick out to me are, in particular, noticing changes from what is someone's baseline. So, for example, in here, it says she's always struggled to connect with her peers, but that appears to have gotten worse. So, we might be talking to about someone who maybe was never super great socially, but that was, their baseline, and that's been the case for a long time. But now we're noticing a change from that, and then it's getting worse. And so that's what we want to be considering. Another piece that often comes up is the idea of conspiracy theories. That's a common thing that a lot of folks talk about and read and believe these days in particular. What we want to be thinking about is how much is it impacting someone's functioning? There are a lot of people that read and learn about these things and do everything else they need to do in their life, and it doesn't impact them. It doesn't get in the way. It's just a thing that you think about here and there. But in the way that, this case example is written, it's starting to take over a little bit, right? She's kind of preoccupied with it. It's impacting her schoolwork, and it's causing a lot of distress. And so that's the kind of thing that we want to be paying attention to, because that can be a suggestion that there's more to be concerned about or to monitor, rather than someone who, is having these thoughts, but is, doing everything else, and it's not really having much of an impact. So as I mentioned, this idea of clinical high risk. So when we talk about an episode of psychosis, kind of a clinically significant episode of psychosis, we're talking about something that's pretty significant, right? It's a pretty significant disruption in functioning. Sometimes it involves folks having to go to the hospital. When we talk about clinical high risk for psychosis, what we're referring to is this, as I said, this kind of group of symptoms that folks might be experiencing that are kind of changes in mood, thinking, perceptions. And then we also take into account family history. And the idea is that folks that end up developing a psychotic disorder often are experiencing mental health concerns earlier in life. And there are a few clinics, as I was mentioning, all these kind of specialized clinics. There are a couple that specialize in this clinical high risk area. And so we do kind of an evaluation to get a sense of all these symptoms and again, ask about family history. And we might determine that someone does meet this criteria of being at this higher risk of developing a psychotic disorder. And then the hope is that we can, get them into treatment sooner, be monitoring these symptoms. And then if someone does go on to develop a psychotic disorder, they're in treatment, they're connected, they have resources, things like that. But importantly, of the folks that we determine to be at this higher risk, only around 10 to 20% of folks do actually go on to develop a psychotic disorder. So what we're also identifying is a lot of other mental health concerns, things related to sometimes anxiety or OCD, trauma, certainly, sometimes autism, things like that. So it, can be identifying a lot of different things, and we're getting folks resources to monitor and kind of see where things go.
Hey, Emily, just real quick, not to interrupt. I see
It's okay.
Melanie Willis said it's interesting that she, as in Alexis, is thinking that the world could be a simulation, but has not made up her mind yet. And I was wondering if you had anything to add to that.
Yeah, thank you. I never am good at looking at the chat, so I appreciate that. Yeah, no, I think that's a great point, and that's kind of what we're talking about in this clinical high risk range, right? And if you think about that continuum too, we're talking about certainty. So like there's still some flexibility there. If you're to ask folks, and it's a lot of what we do in these evaluations for clinical high risk, is to ask people like, how certain are you that this is true? Sometimes folks will say 100%, absolutely, this is absolutely what's happening. A lot of times folks are a little more unsure, and in terms of percentages, like, I don't know, 50, 60%, depending on the day, something like that. And so there is still like room for considering other options. And that is something else that you want to be listening for as well. So yeah, I think that's a great point. Thanks, Sarah. So in terms of other signs or signs to be looking for, these are some of them. The top 4, you might say to yourself, those could be due to anything. You would be right. The purpose of, this list is to have these in mind in addition to, are we also seeing some of these more unusual or kind of intense ideas that folks are having? Is there any element of this more kind of suspiciousness or paranoia? Are folks experiencing some of those perceptual changes that can look like sensitivity to light or sound, or like we said, hearing whispers, seeing shadows? And then also a good way to phrase it sometimes is feeling like your mind is playing tricks on you. because that can mean a lot of different things, and folks can, you know, be able to describe different experiences they might be having. And then we're also taking into account, of course, the family history. The way that I've described it to folks is, if you're, you know, because what we don't want to do is over pathologize, right? We're not now saying everyone that has a couple of these symptoms might have psychosis, but also we don't want to miss signs that, you know, could be relevant and that we would want to be monitoring and paying attention to. And the way that I think about it is, like, as you're working with someone who might be having some difficulties, and you're going through in your mind and saying, okay, could this be a mood thing? You know, could it be anxiety? Is there trauma that I need to know about? Is there substance use? Can we add this to the list? Right? Can we add the idea of someone perhaps having some, you know, risk factors or some signs of psychosis to the list, so that you're keeping it in mind as a possibility without hopefully going too far in one direction of over pathologizing or attributing it to other things. In terms of screening tools, there is this questionnaire, the prodromal questionnaire, PQ-16. It is available on that website I mentioned earlier. I think it's a really great resource with a caveat. So we often hear from folks like, well, I don't even know how to ask about these things. Like, I don't know what kinds of experiences people would be having. I don't know, you know, how to phrase it or what I'm even going to be asking about. So this questionnaire is an excellent resource for that. It's 16 items that are describing the ways that someone might be feeling or the things someone might be thinking if they're having some of these experiences. And so it can be a really nice way to frame a conversation, be a jumping off point for, you know, further discussion. My caveat is that I think a lot of times with screening tools, people can get really hung up on a score. And so if someone has, you know, if someone scores a 12, it means this. If someone scores a 14, it means this. People can say yes to these questions for a lot of reasons, right? Like different perceptual differences just in, you know, the way people experience the world. Trauma can play a big role in, you know, how someone might be having some of these experiences, and they don't necessarily mean that someone has a psychotic disorder. So I always caution folks to use these questions, absolutely, but to try not to kind of live and die by whatever score it is the person gets, because that can, you know, kind of lead you down a road you didn't need to go down, so to speak. And also, when people are telling, you know, you about these sorts of experiences they might be having, just having, you know, an experience like this, perhaps hearing a voice, perhaps having a belief, that in itself doesn't always necessarily indicate some sort of safety concern. We've talked to folks who say, you know, I heard my client or my student, whoever, tell me that they're hearing a voice, and I knew I had to immediately send them to the hospital. That's, you know, very frequently not necessary, right? Because, and what I often encourage folks to think about is the rapport that hopefully you're building with the person who's deciding to tell you these things. If the first time they tell you about it, your reaction is immediately, we have to get you to a hospital, then the likelihood of them perhaps being willing to share those things in the future is maybe a little bit lower, right? Because that was a lot to experience and probably kind of scary. And people, you know, adults exist in the community having these experiences all the time, and that doesn't mean they all need to be in the hospital, right? However, there are absolutely instances where you should consider a higher level of care, and that, you know, there are concerns about someone's safety. Some of these are probably common sense to folks, but, you know, worth reviewing, that if there are really active and difficult to manage impulses for, you know, hurting yourself, hurting someone else, that you can't, you know, effectively safety plan with folks, things like that. Of course, we would want to be thinking about higher level of care. If there are, you know, very significant command hallucinations, so voices or visual hallucinations telling people to do things that are very dangerous to themselves or to someone else, and they're very hard to manage or ignore. If someone seems really out of touch with reality, so meaning that they might be in danger in the community. That could mean like they might be near oncoming traffic, or someone might take advantage of them in the community, things like that. Of course, that would be a concern as well. Or if they're, you know, if someone's behavior is just really very severely disorganized or out of character for them or dangerous in some way. There are these screening tools that you can, I'll send out the slide, or Amanda will send out slides, and you can take a look at those, but tools you might be familiar with, but those are some other options also available on that website that I mentioned as well. So, how do you talk to folks about these experiences? I think sometimes it can feel difficult to know how to understand or relate when someone might be telling you some of these things that perhaps you haven't experienced or are hard to understand. But in my opinion, these experiences can always be understood. One big piece of it is that I think a lot of times folks are feeling like they want to fix it in some way, right? And we're in a helping profession, and so the idea is that if someone is telling you something that's causing them distress, you want to help them get rid of it, right? If it's like a thought that you might be having, like, how do we get rid of that thought? And that makes logical sense, right? However, if you think about, for example, something you believe very strongly, and someone tried to sit you down and tell you all of the reasons why it's not true, that might not feel so great, right? Your intention was not to make someone feel badly, of course. And it might feel that way. It might feel like that person is not being listened to, or, feel maybe a little bit invalidated. And so instead, the goal is to listen, to be curious, to ask questions. And also a lot of times, if the content of what someone is telling you is hard necessarily to understand immediately, you can also be listening for, what emotions might be underlying those experiences. So in the example with Alexis, she believes that the world is a computer simulation. You might say, man, that sounds really scary. That sounds kind of frightening. I can imagine, especially if you maybe are the only one that feels that, that you're the only one that's not part of the simulation, you must also feel really alone. Can you tell me more about that? And that kind of opens the door for a lot more conversation. And if you think about it, if folks are telling anyone else in their lives about these experiences, chances are they're going to be met with things like, what are you talking about? That's not true. No, don't worry about that. Like, here are the reasons that's not true. Just put your mind on something else. Just, forget about it. And so if you can be a person who doesn't do that and instead is willing to listen and think together and ask questions and be curious, that can go a really long way. Both for someone to just feel, heard and validated, and also for you to be able to know more over time that the person might be willing to share more with you in the future. It also gives you the opportunity to then monitor things, because when you first learn about it, it may just be an experience that's kind of happening in the background. But then perhaps over time, things do get worse. And perhaps we do need to consider a higher level of care, and you'll have that information for you to then be able to know, okay, well, now is the time perhaps that we should move forward with different options for treatment, things like that. So how do you ask about these things? Several of these questions are from that questionnaire I mentioned. Research suggests that if you only have an opportunity to ask a couple of questions, that this one is one of the best. As I said before, it's, do you feel like your mind is playing tricks on you? And so it can, folks can interpret it in a lot of different ways, and share different, versions of their experiences and things like that. Some of the other ones are getting at those pieces we talked about, right? So do you have any difficulty telling what's real from what's not? Do you ever feel like you're not in control of your thoughts in some way? Some of those perceptual changes, sensitive to sounds, to light. And then the cognitive piece. Do people have trouble understanding what you're saying? Or are you having trouble getting your point across? Or are you having trouble understanding what other people are saying? Things like that. But then, I suggest people ask these questions, and then, they say, well, now someone said yes, great. What do I do with that? And so the answer is follow-up questions, right? So I just ask more. What is it like? How is it impacting you? How often does it happen? And then importantly, as we were kind of touching on, has it changed over time? An experience I'll often mention is, one kid might tell you, yeah, I've always kind of believed that my stuffed animals were listening when I talked to them. It's something that I've always thought since I was a little kid. When I'm in my room, I tell them about my day. It's just something that's been in my mind for a long time. Doesn't bother me. I don't really think about it unless I'm in my room. Hasn't changed. Doesn't bug me. It's just this kind of thing that is true for me. And so you hear that, but then a different example might be you hear something similar Yeah, I have always thought that my stuffed animals were listening to me. However, in the last few months, now that's kind of all I can think about. And it's actually really stressing me out. It's really freaking me out. And I actually am trying to not be in my room as much as I can because now I'm worried other stuff is listening. And it's just taking over all of my mind. It's really something that's upsetting. So those are two pretty different examples, right? So the former, while maybe a little out of the ordinary, is something that is not causing any distress, has not changed, and is not getting in the way of anything. The second example is all of those things, right? It's gotten worse. It's happening a lot more. It's getting in the way because now the person can't be in their room, and it's causing a lot of distress and really taking up a lot of space in someone's mind. So that speaks to what I was saying before about like, we're not wanting to over pathologize things that are perhaps a little out of the ordinary or that we're not familiar with, but are not causing problems and are not, getting worse. But we also don't want to miss things that are of concern and that, are worthy of further monitoring, and things like that. Another piece of that puzzle is considering culture and someone's background and things that are, common within someone's family or culture, things like that. So another example might be that you talk to one kid who says, yeah, I think my house is inhabited by spirits. And you ask more questions, perhaps you talk to the family and learn more. And you learn, yeah, we all believe that. Absolutely. Yeah, we talk about it all the time. The people that have come before us are still with us in some ways. We joke about it. The back door blows open and we kind of joke, oh, grandpa came to visit today. And it's just part of, our understanding of our world and how things work. You might talk to another kid who says something similar, but then you might learn more from, say, the family or from the kid that you learn, yeah, our family does believe that. Absolutely. We talk about it a lot. And in the last few months, this is all our kid can talk about. And it's really causing them, like it's getting them really upset. And they won't come out of their room because now they're scared about what's happening in the rest of the house. And we ended up missing a doctor's appointment the other day because they just wouldn't leave. And it's really affecting, kind of everything. So again, two very different examples, because what we don't want to do is over pathologize something that's relative, important, normative in someone's culture. And also what we don't want to do is attribute everything to someone's culture when there might be concerns that, again, are worthy of further monitoring and, questioning and things like that. But regardless, how to respond if someone decides to share some of these things with you, hopefully with hope and optimism, right? Thank you so much for sharing this with me. As we said, someone is perhaps, if they're telling other people in their life about this, they might be met with all of these sorts of comments of like, what are you talking about? That's not true. Here, let me explain to you why that's not true. Why don't you stop thinking about that? Things like that. And instead for you to be able, like, thank you so much. Tell me more. This is a lot more common than you might think, and then here's what I know about that. And here's how I would like to support you, or let's talk more about it. And really leaving that door open to be able to talk more. So, what happens when you're going to perhaps talk to family about this? Like if you have a concern that someone you're working with might be having these experiences, or you might want them to receive more treatment or more evaluation. Some of this is probably pretty common sense, but I think it bears repeating. You're wanting to consider the context. What is your rapport like with both the person having these experiences and their family? Is this a family you've worked with for a long time, and you have a relationship with? Is this a family you just met? And how would that impact things? What do you know about their background, their culture, their past experiences, particularly if you know anything about their past experiences with the mental health system? And how might that influence how someone receives this information, is willing to consider it, things like that. And then what might folks already know about psychosis? And inherent in that is in particular stigma. And so what might people know about psychosis from the media that are often very inaccurate portrayals or representations or descriptions? of what psychosis is and isn't. And how will that play a role in how someone might receive this information. And then also deciding who to include, right? I mean, if it's a child, then yes, of course, family's involved, but particularly if it's an older adolescent, you might be able to have a conversation about like, how much of this do you know, am I gonna share with family? You know, are there parts that you'd prefer me to not include? Also taking into consideration both the person who's having the experiences and also family members' level of maturity and also cognitive functioning, right? Is that going to play a role? Is that going to be helpful or perhaps more difficult, make it a more difficult experience? And then what is the person's relationship with their family like? Is that going to be a help or a hindrance in terms of how to have this conversation? And are there things you can do to maybe mitigate that if possible? This is a very long acronym that was developed by colleagues of ours at Beth Israel. The link at the bottom or the citation at the bottom will take you to a short paper that describes this model. But basically, it's how to think about having these conversations. There are some pieces of this that I think are pretty, you know, self-explanatory, common sense. But I think a couple that are worth pointing out are, for example, having a normalizing and non-stigmatizing approach to the conversation. And so again, taking what you now know about psychosis being kind of a typical or you know, common part of human experience and addressing the stigma that exists and, you know, being able to say, yeah, this is what society says about psychosis. This is what we know about it. And this is how we can kind of help you get more information and move forward and have resources. Also the person-centered perspective. So folks for various reasons might, you know, not decide to pursue treatment or evaluation as is suggested. And that's okay, right? Respecting a family's autonomy and the person's autonomy, and hopefully striking a balance of making sure someone has enough information to make those decisions, but then, you know, not also forcing things or kind of pushing things or being too forceful about that kind of thing. And then the empathizing and empowering. So as we talked about, people might receive this information and assume, you know, oh, someone having psychosis means that all hope is lost, you know, everything is over, everything is terrible. And trying, you know, being able to understand, I see why you would feel that way. And you know, empathizing with that. And then also being able to empower the person with the information you have to say, but here's what we know about treatment. Here's what we know about recovery. And here's, you know, how we're going to help you move forward and find some next steps. So I've been mentioning treatment a lot. Well, what does that mean? So the model of treatment is called coordinated specialty care. And the idea is that folks are receiving all different types of treatment from folks on one coordinated team who all work together and who all have expertise working with, you know, adolescents and young adults who have these experiences. So folks would be receiving individual therapy, med management, family therapy, often groups, vocational and educational support, often peer support, all from this one team. And the goal of treatment is always to try to prevent, as we said, the worsening of symptoms, and also the worsening of functioning, really trying to get folks back on track as much as possible. As I also mentioned, there are a few clinics that specialize in this clinical high risk realm. And then there are several clinics that specialize in early psychosis, or what's often called first episode psychosis. And that's for when folks have had kind of a more clinically significant, you know, episode of psychosis. The way it's described makes it sound very black and white. It's not. There's a lot of gray area. So it can be hard to kind of sort that out. And so one way to address that is to call empath. We were created to help folks navigate these kinds of things. The clinics, not only is there, you know, the confusion sometimes of like clinical high risk, early psychosis, also every clinic has slightly different criteria in terms of an age range, catchment area, diagnoses, length of time someone has had symptoms, Insurance is always a nightmare. So the idea is that, you know, folks can contact us first. We have relationships with all of these clinics. So we try to have at least some, you know, as much as we can, a better handle on what clinic, you know, is close to intakes right now. What clinic has a wait list? What clinic accepts, you know, this age, this diagnosis, things like that. And then we can help kind of facilitate those referrals. So our team has been growing. We have been in existence for just about a year and a half now. We are a program of the Brookline Center, but we are a statewide resource. So we exist at the Brookline Center, but we work with folks across the state. We are also free. And two of my colleagues are here today, as we said, Tanya and Sarah. You'll hear from them in just a minute. We also have Rebecca, who's our coordinator. She does all of the initial screening, kind of answering all of our initial outreach, emails, phone calls, et cetera. Charlene is a LMHC. She's a clinician that works with us and does a lot of coaching with folks and care coordination. Importantly, Empath is not a clinical program. So what that means is we're not Empath ourselves. We are not doing therapy. We are not prescribing medication. We are connecting folks to resources to get them those services, that level of care. And then we do work closely with the Cedar Clinic. Cedar is a program of the Brookline Center. And Cedar is one of those clinical high risk programs that I think sometimes folks have heard of. So we work with Dr. Stern and Dr. Weber at the Cedar Clinic. We also work with Dr. Emily Klein, who's at BMC, the RAP, the early psychosis program there. Our wonderful data coordinator, Jimmy, and then also Dr. White, who was the medical director of the Brookline Center for many years and was kind of the main founder of Empath and also of Bright. Folks are, I think, here familiar with Bright as well. So what kinds of things can we do? For providers, we do a lot of consultation. And so that means talking with folks about, you know, students or clients that they might be seeing to think through, you know, here's what's going on. Might this be psychosis? Might this be something else? What are resources that, you know, I should be passing along? What are questions I can ask? You know, things like that, how to think about these cases. We can do that on a one-time basis. We can do it on a long-term basis if folks are continuing to work with people. And then, of course, we can also help with those referrals to those programs. We think about it as how can we help folks to be providing psychosis-informed care. So in the way that you think about trauma-informed care, not everyone is an expert in trauma, but you do have an understanding, a basis of understanding for how trauma can impact people, what it might look like to talk to someone that's had a traumatic experience, things like that. And so in a, you know, somewhat similar way, we're kind of hoping how can we make sure people have enough information and resources and honestly confidence to be able to talk to folks about these kinds of experiences. Because, you know, these specialized programs I was describing, first of all, there aren't unfortunately not enough spots to, you know, have everyone who might benefit from these programs be able to enter one. But also not every single person with these experiences necessarily needs that higher level of care. They can continue to see providers in the community and get care there, but it can be really important for the providers to have that information and that confidence to do that work. And then for adolescents and young adults and their families, we work directly with them to, again, help with those referrals to get them to those programs if needed and if possible. But also Tanya and Sarah are a huge part of our work because we do a lot of support and for the families that we're talking to. And Tanya and Sarah share their own experiences and are kind of a listening ear, able to answer questions about their experiences and things like that. And then we can also do, as I said, kind of some care coordination and help folks sort out, you know, getting records from a previous hospitalization or, you know, things like that that can get a little overwhelming. So last are just a couple slides for links that you can click on. Obviously, once you have the slides, they're not useful to you right now. But I want to point out that there's a set of presentations that have been done by another organization in Massachusetts that we work with, MapNet, who also kind of specializes in early psychosis. And these are covering common comorbidities. And each of them can be their own presentation, which is why they are. But it covers importantly things like substance use, OCD, trauma, suicidality, autism, and kind of thinking about how those things can overlap, how they can look similar but are different, things like that. And so I would encourage folks to take a look at those if you're interested. And then these are some resources for adolescents and young adults, some support groups, peer support groups, some content creators online who share their own experiences with psychosis, and then also some resources for families. Couple books that folks have found helpful, in particular, The School of Hard Talks was written by our colleague that I mentioned, Dr. Emily Klein. She developed Milo, or motivational interviewing for loved ones. And the idea is that it teaches parents or family members motivational interviewing skills to then use with their child or their, loved one. A lot of times what we are hearing, we talk a lot with families who say, well, I want to, make my kid go to treatment, right? How can I make my kid do the thing that I think they should do? And using these MI skills can kind of make those conversations go a little better, to kind of come to a shared goal, shared understanding of the problem, things like that. There's also a link to some modules online that use the same content, if folks are curious about that. So